Hi friends, in this video we'll study the anatomy of the portal vein as well as the portacaval anastomosis. To begin with, the portal vein or the portal system together itself includes all the veins which are draining the abdominal part of the digestive tube. Okay, so the whole part of the digestive tube of the abdominal part will be draining into a plexus of veins which will be finally drained to the portal vein. So that is called as portal system. Except the whole of the digestive system in the abdomen except the lower part of the rectum as well as the anal canal. They will be draining into the systemic veins. Okay. It also receives the veins from the spleen, pancreas as well as from the gallbladder. So how this portal vein is formed? It is formed by the union of two important veins, that is the superior mesenteric vein as well as the splenic vein at the level of L2 vertebra behind the neck of the pancreas and in front of the inferior vena cava. So if you see here in this picture, you can see this is the superior mesenteric vein and this is the splenic vein. The superior mesenteric vein joins with that of the splenic vein at the level of L2 vertebra. At the level of L2 vertebra, that is second lumbar vertebra, behind the neck of the pancreas. So if you see here, this is the pancreas. So this is the neck of the pancreas. This is the head of the pancreas. This is the uncinate process, and this is the neck, and this is the body of the pancreas. So behind the neck of the pancreas, not in the front, it is behind the neck of the pancreas. This vein is formed by the joining of the superior mesenteric vein with that of the splenic vein. Okay, together it forms the portal vein. Okay, so at the level of L2 vertebra, behind the neck of the pancreas and in front of the inferior vena cava. So this is how the portal vein is formed. Okay. What are the peculiar features of this portal vein? Even though this is a vein, it has some peculiar features which differentiate this vein from other veins. One is it begins like vein, like by joining of the capillary plexus from capillary plexus, and then the tributaries which join together to form the portal vein. So it begins like veins from the capillary plexus of gut and ends like arteries by dividing into hepatic sinusoids. So it divides into branch later. If we see, a portal vein will give rise to branches. Usually they are tributaries, but there are branches in case of the portal vein, and finally it ends as hepatic sinusoid. Divides into the hepatic sinusoids. Okay. It is devoid of valves. As you know, the veins will have valves which will help the blood to flow in unidirection, okay, and against gravity also. But in case of portal vein, there are no valves. It is devoid of valve. Even though developmentally, initially they will be present, but later they disappear. So the portal vein is devoid of valves. This is the second peculiar feature. The third important peculiar feature of this portal vein is along with the venous blood, it also carries absorbed products of the digested food. Usually the arteries are the vessels which will be supplying the blood to different parts of the body along with the nutritions required, the oxygenated blood along with the nutritions required to all the parts of the bodies and cells and tissues. But in this condition, the portal vein, which is coming from the different parts of the small intestine, it will be draining all the nutrients which are absorbed, and it will be pumped into the portal vein and from there into the liver for metabolism. So here the portal vein, along with the deoxygenated blood, it also carries nutrients which are absorbed from the mainly from the small intestine. It also acts as a reservoir of blood. Almost one third of the entire blood may be stored in the portal system. As you know, the portal vein is mainly coming from the abdomen, mainly from the intestine, and the intestines are highly vascular highly vascular regions because they have to absorb all the nutrition from the small intestine mainly, and they have to be pumped into the portal vein. So they are highly vascular, so a lot of vessels are there. The fifth peculiar feature is there are two streams of blood which are flowing within the portal vein. One coming from the superior mesenteric vein and passes through the right branch of the portal vein, and the second one is coming from the splenic vein and passing through the left branch of the portal vein. So here you can see here this is the right branch shown in blue color, blood from the superior mesenteric vein. It will be absorbing blood from the different parts of the small intestine as well as part of the large intestine, and it flows through the superior mesenteric vein through the right part of the portal vein directly into the right branch of the portal vein and to the right side of the liver. The left branch, the splenic vein, will be draining the most of the blood from the spleen as well as from the remaining part of the large intestine, and it is shown in purple color. Okay, blood from the splenic, gastric as well as the inferior mesenteric vein will be flowing through this. Okay, and the blood will flow through the left part of the portal vein, and from there into the left branch of the portal vein and to the left lobe of the liver without much mixing. So only a small part of the blood mixes up, and it is supplying mainly the middle part of the liver. So there is no much mixing between the right side, the blood coming from the superior mesenteric vein with that of the blood coming from the splenic vein. Okay, so there are two separate streams within the portal vein. Two streams of blood will be present, one coming from the superior mesenteric vein and passes through the right branch of the portal vein, and that coming from the splenic vein will be passing through the left branch. Okay, most of the time most of the blood will be separated. Okay, approximately 1.5 liters of blood per minute will circulate through the liver, out of which 1.2 liters comes from the portal vein. So the liver is supplied by both the portal vein as well as the hepatic artery. Usually the blood supply will be from the artery, but the peculiar feature of the liver is it is supplied by the hepatic artery as well as the portal vein. Portal vein is supplying the liver. Okay, even though usually the veins will drain, but here in case of this condition the liver is supplied by the portal vein as well as the hepatic artery, and out of which usually 1.5 liters of blood will be passing through the liver per minute, circulates through the liver, out of which 1.2 liters comes from the portal vein. So the main supply is from the vein, and only 300 ml comes from the hepatic artery. The small quantity, almost 20% of the blood is coming from the hepatic artery, and 80% is coming from the portal vein. This is the peculiar feature. Okay, so where the portal vein is supplying the liver, and it is the major supply of blood to the liver. Okay, because it has to bring all the nutrition from all the absorbed part of the intestine. From where it is absorbed, the nutrition will be pushed back into the liver. Okay, almost 75% of the nutrition of the liver is provided by the portal vein and remaining from the hepatic artery. So the main nutritions are coming because the blood coming from the intestine, especially from the small intestine, the stomach and everywhere, so where the main absorption of the nutrition is taking place. And so all the nutrition, almost 75% of the nutrition for the liver will be coming from the portal vein, and the remaining, that is 25%, coming from the hepatic artery. Okay, the length of the portal vein. So the portal vein joins together the splenic vein as well as the superior mesenteric vein joins together at the level of L2 vertebra and form the portal vein, and this whole thing is the portal vein till it divides, branches. Okay, as I said, usually the artery branches, but in case of this condition the portal vein is also branching, it is giving two branches. Okay, so from here to here, what is the length of this portal vein? It is almost 8 centimeters long and almost 2 centimeters in width. Okay, so it is quite a broad vein. Okay, big vein, as we can say. Okay, so this is the 8 centimeters in length and almost 2 centimeters in width. Okay, and what is the portal pressure? There is a pressure almost of 10 to 15 millimeters of mercury. Okay, so this is the pressure. So this pressure is important because later in some condition there might be the portal pressure will increase. We'll see those conditions. Okay, coming to the cause. So it has an extrahepatic part as well as the intrahepatic part. As we see, all the part which we are seeing here, this will be extrahepatic, outside the liver. But once it branches, it goes inside, and again it further branches into smaller veins. Okay, so there is an intrahepatic part inside the liver. Also there is the part of the portal vein, okay, and its branches. So there is an extrahepatic part which is outside and intrahepatic part which is inside the liver. Okay, so this is how it is there. Coming to the relations, we'll not go into relations in detail, just briefly I will tell you. So this portal vein is divided into infraduodenal part, which is below the duodenum. See here, this is the duodenum, the first part, second part, third part, and the fourth part. So this is the first part. So the part of the portal vein below the duodenum, this is called as the infraduodenal part. This part before after the joining of the superior mesenteric and the splenic vein, whatever part is there, so this is called as the infraduodenal part. The part which is behind the duodenum, that is called as the retroduodenal. Retro means behind, retroduodenal, behind the duodenum, and supraduodenal, which is above the duodenum, okay, which will continue upwards, and then it branches into a right and left branch before it enters the liver. Okay, so this is called as the supraduodenal part. So infraduodenal part, retroduodenal which is behind, and the supraduodenal which is above. So if you see the infraduodenal part, so this is in front, you can, as we have seen already, there will be the neck of the pancreas itself. Okay, so the neck of the pancreas will be in the front, and behind there will be the abdominal aorta as well as the inferior vena cava. Retroduodenal part, as the name itself indicates, so it is behind the duodenum. So in the front will be the duodenum, and behind will be the abdominal aorta as well as the inferior vena cava itself. And supraduodenal part, in the front will have the liver itself as well as some part of the intestine, small intestines, and behind will be the inferior vena cava as well as the abdominal aorta. Okay. Okay, now coming we will further see how it divides. So here is the hepatic artery and the larger structure, that is the portal vein. It is going into the liver, intraduodenal part, intrahepatic part. So then it is divided into multiple branches. Okay, so if you take a closer look of this part, so this is how it looks like. These are the hepatic sinusoids, and if you see here, the blood is coming from the artery as well as the vein, and the bile duct is also there. Okay, so the blood is coming into the each hepatic sinusoid. So this is the section of the hepatic sinusoid, and here you can see this is the portal vein, a branch of the portal vein, a branch of the hepatic artery. Both are supplying the liver, the hepatic sinusoids. Okay, so this is the blood coming from the portal vein, this is the blood coming from the hepatic artery. If you see here, they both are joining. Okay, the mixture of the arterial blood as well as the venous blood will be taking place within the hepatic sinusoids, and they go toward the central vein. So here you can see here is the central vein, intralobular vein or central vein. Okay, and from there all this central vein join together to form the hepatic vein, from where the venous drainage of the liver will be taking place. Okay, so this is how hepatic sinusoids look like. Here will be the branch of the portal vein, hepatic artery as well as the bile duct, and here is the central vein, and the blood will be going towards this side, towards the central vein. Okay, so here now they have shown you much more clearly a part of the hepatic sinusoid, so that you can appreciate the portal vein, branch of the portal vein, branch of the hepatic artery. If you see here, the arterial blood and the venous blood are getting mixed up. Okay, here also you can see hepatic artery and the venous blood gets mixed up in the hepatic sinusoids, and it is draining through these sinusoids towards the central vein. If you see the bile duct, the bile canaliculi, so the bile flow will be opposite to the arterial and venous blood. Okay, flow of the artery. So the blood is flowing toward the central vein, and the bile is flowing away from the central vein. Okay, so this is the picture. This is how it looks like in the histological sections, and here they have graphically shown you the mixture of the arterial and venous blood flowing towards the central vein and the bile flowing away from the central vein. Okay. Now coming to the tributaries of the portal vein. So tributaries of the portal vein, the main veins which together join to form the portal vein is the superior mesenteric vein and the splenic vein. So here is the superior mesenteric vein joins with the splenic vein to form the portal vein. There are other tributaries which will be draining into the portal vein. One is the right gastric vein. This is the right gastric vein. Then the left gastric vein. Both will join or communicate with each other near the lesser curvature of the stomach. Okay, so this is the right gastric vein, then the left gastric vein. Then we also have the cystic vein. So here is the cystic vein which will be supplying the gallbladder. Then we have the paraumbilical veins. Okay, paraumbilical vein. Then finally we have the superior pancreatico-duodenal vein. So as the name indicates, it will be draining the venous blood from the pancreas, from the head of the upper part of the head of the pancreas, as well as the duodenum, the first and the second part of the duodenum. So that is called as the superior pancreatico-duodenal vein. So all these are the tributaries of the portal vein itself. The superior mesenteric vein and the splenic vein will be the main veins which will join to form the portal vein. Then the right gastric as well as the left gastric, the cystic, paraumbilical as well as the superior pancreatico-duodenal vein. All these are the tributaries of the portal vein. So here you can see, so this is the superior mesenteric vein, this is the splenic vein. The inferior mesenteric vein, as I said, will be draining to the splenic vein and from there into the portal vein. And here you can see the left gastric vein and the right gastric will communicate with each other at the lesser curvature of the stomach. And here we can see these are the paraumbilical veins coming from the umbilicus. Okay. And here will be the cystic vein which has not been shown. Okay, so these are some of the branches, tributaries of the portal vein. Okay, coming to the something called as portacaval anastomosis. Portacaval. So this is the kind of sites where the portal veins anastomose with the vena cava veins. Okay, the superior, or usually it will be the inferior vena cava. So the portal vein anastomose with the branches of the inferior vena cava. So what are these sites? Okay, one is at the lower end of the esophagus. The second is at the lower end of the rectum and the anal canal. The third is at the umbilicus. The fourth is behind the peritoneum. The fifth is at the bare area of the liver, bare areas of the liver, where there is no peritoneal covering for the liver. Okay, then the sixth is in the falciform ligament, one of the ligament of the liver itself. Okay, accessory portal system of the SAPI. Okay, then the seventh is at the fissure of the ligamentum venosum. That is also a ligament within the liver. Okay, that is the ductus venosus will become the ligamentum venosum. Okay, so these are some of the sites where there will be the portal blood will be mixing or anastomose with that of the branches of the inferior vena cava. One is at the lower end of the esophagus, the second is the anal canal as well as the lower end of the rectum. The third is at the umbilicus, the fourth is behind the peritoneum, the fifth is the bare area of the liver, the sixth is the falciform ligament, and the sixth is the falciform ligament, and the seventh is the fissure of the ligamentum venosum. All these are the sites. If you can see here, the first one here, that is at the lower end of the esophagus, where the portal vein will be communicating with that of the vena cava opening, especially the superior vena cava here in this condition. Okay, and in the second part so here they have shown the difference between the colors. So the portal vein are shown in the dark color, dark blue, and the inferior vena cava is shown in the light blue color. So this is the second side where the lower part of the rectum and the anal canal. Okay, the third is at the umbilicus, and the fourth is behind the peritoneum, and the fifth will be at the the falciform ligament. Okay, so all these are some of the sites where there will be the bare area of the layer. Okay, so the fifth will be bare area, and the sixth will be at the falciform ligament, and the second is the ligamentum venosum. We'll see them one by one. Okay, to begin with, at the lower end of the esophagus. So at the lower end of the esophagus, so what are the veins which will communicate with each other? One is the esophageal tributaries of the left gastric vein. So here is the stomach, this is the left gastric vein, which will be supplying the part of the lower part of the esophagus, and it will be draining into the portal vein. But there are also veins which are coming from the esophageal tributaries of the hemiazygous vein. Okay, so this is the hemiazygous, inferior hemiazygous, this is the superior hemiazygous, this is the azygous vein. So this is the inferior hemiazygous, which is also draining the lower part of the esophagus. So this is the site where the portal vein will communicate with the veins of the inferior vena cava. Okay, so it is draining either into superior vena cava or partly into the inferior vena cava also. Okay, so this is the site where the portal vein, which is shown in light blue color here, with that of the veins of the inferior vena cava, which are shown in the dark blue here. Okay, one is the lower end of the esophagus. So the portal vein, portal system is communicating through the left gastric vein, and the systemic veins, that is the superior and inferior vena cava, will be communicating to the hemiazygous veins. Okay, this is one of the side. During portal obstruction, so if there is any obstruction, okay, in the portal vein, or because of the disease of liver itself, like cirrhosis, there will be increase in the portal pressure. As I said, usually it will be 10 to 15 millimeters of mercury, but because of this pressure, reverse pressure, there will be increased pressure, and this leads to the venous blood flowing in reverse direction. Because it cannot enter the liver, so it will start flowing through the reverse direction, and it starts communicating here, and it tries to flow through the systemic vein. In this condition, it leads to something called as the esophageal varices. Esophageal varices, a very bleedy complication, where there will be severe bleeding through the vomiting. So blood will come through the vomitus. Okay, so this is called as esophageal varices. As the second condition is at the lower end of the rectum and anal canal. Here the rectum and the anal canal, this will be here the systemic, the portal veins will be coming from the superior rectal vein. The superior rectal vein will be draining into the inferior mesenteric vein, and from there into splenic vein and into the portal vein. Okay, so this is the superior rectal vein. But the middle and the inferior rectal veins will be through the systemic vein, that is, they will be draining into the branches of the inferior vena cava. Okay, so there is communication between the portal vein and the systemic vein. Portal vein through the superior rectal vein, and the middle and inferior rectal through the systemic vein. So in case of there is portal obstruction and increased pressure in the portal vein, that leads to a condition called as the internal rectal piles. So the blood starts flowing in reverse direction, the portal obstruction, and it tries to communicate with tries to flow through the systemic vein. In this condition, there will be increased pressure here, and then it starts bleeding, that is called as the internal rectal piles. Okay, so this is the second side where there will be portacaval anastomosis. One is in the lower end of the esophagus, the second is the lower part of the rectum and the anal canal. The third is near the umbilicus. Okay, here the umbilical veins, so they have shown in the black color here. Okay, which will be draining into the left branch of the portal vein. Okay, and the superior, all the veins of the abdomen, here they have mentioned, because for simplification they have mentioned the veins of the anti-abdominal wall, like the superior epigastric, the lateral thoracic, superior epigastric, so superficial epigastric, inferior epigastric, posterior intercostal, lumbar veins. All these will be veins of the anti-abdominal wall, which finally drain into the inferior vena cava. So this become the systemic vein. So systemic veins communicating with that of the parumbilical vein, which is part of the portal vein. This is the third side near the umbilicus. Okay. Obstructions will and increased pressure within the portal vein will leads to a spokes of wheel-like condition called as the caput medullae. Later we'll see the picture where the spokes of wheel, it looks like this spokes of wheel because the blood starts trying to pass from the paraumbilical vein into the systemic veins. Okay, so it leads to a condition called as caput medullae. The fourth is behind the peritoneum. Behind the peritoneum, the splenic and colic veins, that is which will be part of the portal system, will be trying to communicate with that of the left renal vein and other tributaries of the inferior vena cava, the veins of the ribs. Okay, so it will this splenic and this is the splenic vein here, and the colic veins through the inferior mesenteric vein or superior mesenteric vein, they all try to communicate with that of the left renal vein, especially from the inferior mesenteric vein and the splenic vein. They will be trying to communicate with the left renal vein and other tributaries of the inferior vena cava, which is behind the peritoneum. The fifth is in the bare area of the liver. The bare areas are those parts of the liver where the liver is not covered by the peritoneum. Okay, so here the portal radicals of the liver, communicates, portal radicals of the liver which are a part of the portal vein will try to communicate with the diaphragmatic vein. This see here, just above the liver will be the diaphragm, and from there some of the veins will be draining the liver, especially the superficial part. So those veins will be systemic veins. So here also there will be communication between the portal vein and the systemic vein. In the falciform ligament, which is a ligament of the liver, the paraumbilical veins, these are the paraumbilical veins which are coming from the portal system, will try to communicate with the diaphragmatic veins again. Okay, diaphragmatic veins in the front. So here this was at the bare area on the top, and now in the front there will be diaphragmatic veins also. Okay, which will be coming from the systemic vein, accessory portal system of the sapling. The seventh is the fissure of the ligamentum venosum. Again, it is the ligament of the liver. As I said, the ductus venosus will become the ligament later, ligamentum venosum. So this here, the left branch of the portal vein, in case of the fetal conditions, in the fetal life, will start communicating with the inferior vena cava through the ductus venosus. This picture shows all the portacaval anastomosis, especially to show the anastomosis behind the peritoneum between the left renal vein and the splenic vein. You can see here blue colored structure which has been shown. This is the left renal vein. Blue will be here in this picture will be the systemic veins, and the dark blue will be purple will be in the portacaval veins. Okay, portal veins and their tributaries. So here you can see the left renal vein, which is a systemic vein communicating with that of the splenic vein. So this is portacaval anastomosis behind the peritoneum, and here you can see near the lower part of the rectum and anal canal, portacaval anastomosis. Then here this is in the lower part of the esophagus, and here between the bare area of liver and diaphragm. Okay, this is the portacaval anastomosis here, and here around the umbilical cord, and finally here between the falciform ligament and the diaphragmatic veins. Okay, so these are some of the sites where the portacaval anastomosis will be taking place. Okay, now coming to the development of the portal vein. Portal vein develops from two vitelline veins around the duodenum. Here in this picture, if you see, this is the duodenum, and the right and the left vitelline veins are there on either side. They are separated initially. So here in this picture graphically, if you want to see the development, so this is the duodenum and the right and the left vitelline veins. Initially they are separated, there is no communication. Later communication develops between the right and the left vitelline veins in the upper part, which is proximal, and this will be ventral communication in front of the duodenum. This is the duodenum, so this is the ventral communication. Then in between there will be communication between the two vitelline veins, but now here the communication is behind dorsal. Okay, dorsal communication between the two vital veins. Then again there will be third communication, which is ventral, in front of the duodenum. So there are two ventral communication, proximal as well as distal, and one dorsal communication. So here in this picture, if you see, so initially it will be two separate veins, later there will be communication. This is the proximal ventral anastomosis, and this is the the distal ventral anastomosis, and here will be the dorsal anastomosis, which is behind the duodenum, and two are in the front of the duodenum. So this is how it develops. Then there will be formation of the splenic vein and communication of splenic vein as well as the superior mesenteric vein. This is the superior mesenteric vein. This will be the splenic vein, which communicates with that of the left vital veins. Later, what happens? Slowly parts of the vital veins start disappearing. Initially, it will be the lower distal part of the right vital vein which disappears. Distal part, then the middle part of the right vital vein disappears. Then the anastomosis, the distal ventral anastomosis, that disappears because there is no right vital vein. So what is the use of the distal ventral anastomosis? So that part disappears. Then the left vital vein also start disappearing, the distal parts, okay, till the communication of the superior mesenteric vein as well as the splenic vein. Till there, the whole of the the left vital vein also disappears. Then even the proximal part of the vital vein, the left vital vein, will disappear. So what is remaining is just the splenic vein, the superior mesenteric vein, the splenic vein, then the dorsal anastomosis, as well as the proximal part of the right vital vein, as well as even the proximal ventral anastomosis also remains. So this is how it looks like. Okay. So here the right vital part of the distal part of the right vital vein has disappeared. Then the distal ventral anastomosis disappeared. Then the distal part of the left vital vein also disappears. Even the proximal part of the left vital vein disappears. Just finally it remains will be the superior mesenteric vein, splenic vein, the dorsal anastomosis, as well as proximal part of the right vital vein, as well as the proximal ventral anastomosis. Now it will be like this. Later it straightens and the duodenum twist and the portal vein, this the portal vein, which is finally portal vein is formed. So there will be the superior mesenteric vein down and the splenic vein, and the portal vein becomes straight, and the two communications. Okay, this is the proximal ventral anastomosis, which becomes long and becomes branch of the portal vein. The left portal vein and the right portal vein will be the right portal branch will be on this side. Okay, and this is the liver. Okay, so this is how the development of portal vein will take place. Now coming to the last part, that is the applied aspects or the clinical aspects or the clinical anatomy, about the portal hypertension. As we said, sometimes there might be hypertension within the portal vein, increase in the pressure. We said that normal pressure is 10 to 20 millimeters of mercury, but if it increases more than 40 millimeters of mercury, then it is called as portal hypertension. This might be because of the cirrhosis. Usually the most commonest will be the cirrhosis of liver, or sometimes the thrombus formation within the portal vein, or it is coming from some other side and get stuck within the portal vein and block the portal vein, which leads to portal hypertension, or sometimes in a condition called as Banty's disease. So more than 40 millimeters of mercury, and that leads to a condition with some particular symptoms like ascites. Okay, ascites is the accumulation of fluids within the abdomen. Okay, then congestive splenomegaly, because of because the portal there is portal hypertension and there is pressure, increased pressure within the portal vein itself. Now the blood try to flow back to the splenic vein, which leads to congestion of the spleen as well as the increase in size of the spleen. So that condition is called as congestive splenomegaly. Okay, then a condition called as caput medusae. We saw that there is communication between the portal vein and the systemic veins near the umbilicus. So whenever there is increased pressure in the portal vein, it leads to a condition where there will be spokes like radiating in the fashion near the umbilica, that will be called as caput medusae. Then it also leads to esophageal varices. where there is communication between the esophagus, between the systemic veins and the portal veins. Okay, so that leads to esophageal varices as well as the hemorrhoids near the rectum, lower part of rectum and anal canal. Okay, so this is the condition where the different veins, systemic veins, that is from the anti-abdominal wall communicating with the portal vein, the umbilical veins. So this is how it will be around the umbilicus. So if there is increase in pressure, then it leads to a condition called as caput medusae. This is how it looks like, caput medusae. Then it also leads to ascites. This is how the ascites will look like. There is size in the belly and filled with fluids. Okay, so this is the condition where there will be caput medusae. Around the umbilicus there are spokes of vein, which looks like the spokes of the vein. So this is called as caput medusae. And now here they are showing the portacaval anastomosis around the lower part of the esophagus, which leads to, if there is portal hypertension, leads to esophageal varices. Okay, so this is how it looks like in the esophagus. If you open and see, then it will looks like the beads within the wall of the esophagus, which leads to difficulty in swallowing. And if there is intake of the hard food material, then it will scratch on this and it leads to severe bleeding and vomiting of the blood. This is a condition where there is the hemorrhoids. This is the internal hemorrhoids and the external hemorrhoids. So where there is communication again between the portal vein and the systemic veins. So it leads usually to the, if there is portal hypertension, it leads usually to the internal hemorrhoids or piles. Okay, so this is all about the portal vein as well as the portacaval anastomosis. If you have any questions, you can write to me and I will try to answer. These are my references. Thank you very much. Hi friends, if you liked my video and if you want to see similar kind of videos in the future, subscribe to my channel as well as like the video. Press the bell icon so that you can get regular updates and you will be the first to get the updates. Then you can also comment as well as share this video with all your friends so that all can benefit from this. Thank you very much.